So she said, I will present you this report about infecting fungal endocarditis. Um, 47-year-old man. Um, Pardon. Okay. Um, was diagnosed with autoimmune hepatitis 4 months before the onset of fungal endocarditis. So he was initially treated with methylprednisolone at the dose 64 milligrams per day. Then the dose was reduced to 8 milligrams per day. While undergoing corticosteroid therapy, he developed diabetes, which was treated with insulin. Um, the day before he was admitted to the hospital, his vision on his right eye has significantly deteriorated. He reported seeing red spots and foggy curtain in the affected eye. He had otherwise no history of eye surgery or vision problems, and also he denied using drug. So he lived with his family and had hamsters pet. Interestingly, he mentioned that a few days before his symptoms started, he had been cleaning molds from the walls of their apartment. So, on the day of admission to the hospital, his condition worsened and his vision decreased on the point that he could only count fingers. So, otherwise, the status was normal. He has only a fever of 38.2 degrees Celsius. Here are the initial laboratory findings. So it reveals elevated white blood cells count, mild thrombocytopenia, increased liver enzymes, and elevated inflammatory markers. But procalcitonin level was normal. The Department of Ophthalmology performed fundoscopy and vitrectomy. The fundoscopy findings suggested a fungal etiology and revealed the following: hyperemia of the optic disc, dense white exudates in the peripheral vitreous, rot spots, intraretinal hemorrhages, extensive premacular infiltration, and also severely damaged macula. As I said, vitrectomy with aqueous and vitreous sampling was performed, and samples were sent to microbiology for culturing. They sent also blood cultures and blood for serology for toxoplasmosis and Lyme disease. Following vitrectomy, antimicrobial therapy was initiated. Intravitreally therapy with vancomycin and ceftazidime was started. Additionally, systemic intravenous antibiotic therapy with moxifloxacin in and flucloxacillin was started. Due to the suspected fungal etiology, was also fluconazole initiated. So here are the microbiological results. Serology tests for toxoplasmosis and Lyme disease were negative, but serum fungal markers were positive. The galactomannan level was 2.8 by ELISA, and the beta-D-glucan level was over 523 picograms per milliliter. Microscopy of the vitreous samples was negative. Also, blood culture, bacteriological culture of the eye were negative. But mycological analysis revealed positive samples in two vitreous samples grow Aspergillus fumigatus. On day 3, transthoracic and transesophageal echocardiography were performed. Three large vegetation up to 2 centimeters were found on the posterior left lap of mitral valve. Moderate mitral regurgitation and evidence of valve destruction were also present. Based on this result, the diagnosis was clear infective endocarditis, and the patient was sent to Department of Infectious Disease for treatment. Um, when the patient condition was stable when he arrived at the department. A loud systolic heart murmur was present across the entire precordium. His right eye was red and eyelids were swollen, and his vision improved to 3 meters after vitrectomy. Um, a tender nodule was present on his left thumb, suggesting an osseous node. The patient underwent CT imaging of the chest, abdomen, and head. The chest CT revealed consolidation with cavitation in the left upper lobe, indicating an infection. Small nodular gram class opacities were also present in both lungs. Notably, septic emboli were present in the right kidney and spleen. There were no changes in CT scan in the head. Based on the diagnostic findings and guidelines, the following treatment changes were made. The fluconazole was replaced with liposomal amphotericin B and voriconazole. Amphotericin B was also administered intravitreally. Systemic antibiotics were stopped. Additionally, the immunosuppressive therapy was changed from methylprednisolone to budesonide. Next day, on day 4, the patient's condition suddenly worsened. He developed shortness of breath and needed supplemental oxygen. He was also tachycardic with increased heart rate of 110 beats per minute. At the same time, he experienced severe pain in his right leg, which turned pale and pulseless distal to the knee joint. CT angiography revealed or confirmed an arterial embolus. The patient underwent emergency mitral valve replacement and common femoral artery embolectomy. Intraoperative histology of the mitral valve tissue confirmed fungal etiology. Aspergillus fumigatus was cultured from both the mitral valve tissue and also from the femoral artery embolus. Here are the clinical outcomes and follow-up findings. So cardiac function improved after surgery and the initiation of heart failure therapy. Follow-up echocardiography revealed no residual signs of infective endocarditis. Visual function improved, though mild blurriness persisted. And follow-up Aspergillus galactomannan assays were negative. According to guidelines, the patient was initially treated, as I said, with a combination of parenteral liposomal amphotericin B and voriconazole for 4 weeks. This was followed by a brief course of oral voriconazole, 1 week, and during this time, a significant increase in liver enzymes was detected. Despite therapeutic drug monitoring and appropriate voriconazole levels, a liver biopsy confirmed drug-induced liver injury. So they switched to liposomal amphotericin B, And during this therapy, hepatic enzyme decreased. However, his kidney function worsened. So, after 2 weeks of therapy with liposomal amphotericin B, the patient was in good clinical condition. He improved significantly. Inflammatory markers were low, and both liver and kidney function had improved. Therefore, at the patient's own request, he was discharged on oral triazole therapy. First with voriconazole for 1 week and then with isavuconazole for 2 weeks. However, both resulted in recurrent hepatotoxicity. Since there were no other options in guidelines, they consult with experts and started with liposomal amphotericin B intermittent at a dose 3.4 milligrams per kilo weekly as maintenance therapy for 12 months. What was the follow up? So, 10 months after treatment, the patients remained clinically stable and showed no signs of recurrence of infective endocarditis. His liver function improved over time, and the planned switch from budesonide to azathioprine for immunosuppressive therapy was postponed by 1 year. His vision improved following cataract surgery on his right eye, but has not fully recovered. Creatinine level remains elevated but stable, and fungal markers are negative. So he needs ongoing clinical and laboratory follow-up. Let's briefly look at the risk factors for fungal endocarditis. Uh, Fungal endocarditis on a native valve is very rare, particularly when there is no severe immunosuppression or prior cardiac disease. The most common risk factors are prosthetic heart valve and hematologic malignancies. Other important risk factors include solid organ or hematopoietic transplantation, intravenous drug use, and diabetes. There have been also rare cases reported in individuals who have undergone splenectomy or who have no identifiable risk factors. So the main risk factors for our patients were autoimmune hepatitis in remission, low dose corticosteroid therapy, and diabetes. So therefore, he was not severely immunosuppressed, and he developed endocarditis on a native valve, which is very rare. This case is unique due to the patient's initial low risk for invasive aspergillosis, the clinical presentation, and the successful management despite the poor prognosis and side effects associated with first-line antifungal therapy. In this case, early diagnosis based on positive vitreal fluid samples was crucial. Fortunately, the patient also did not experience any central nervous system complications, enabling early and successful valve replacement. So, in conclusion, if a fungal infection is suspected, the appropriate microbiological test and echocardiography should be performed promptly. The rapid diagnosis is associated with early treatment and improved survival. Additionally, research is needed on the efficacy of intermittent liposomal amphotericin B or new peroral antifungals for long-term antifungal therapy. So thank you for your attention.
Thank you, Tareya, for a great presentation and very interesting case. I suggest to discuss about this after our last presentation in this room, then we will move in another room. It is my great pleasure really to invite Professor Mija Stihić from University of Tuzla, Faculty of Medicine and University Clinical Center Tuzla. He is a medical microbiologist, a specialist, and subspecialist in clinical immunology, with special focus on hospital infections in high-risk patients. Clinical and academic work is dedicated to improving the diagnosis, individualized management, and outcomes of patients with severe complication in intensive care unit. He will present clinical case from Bosnia and Herzegovina, clinical case of Cryptococcus meningitis after liver transplantation.
Thank you for the introduction. And once more, I would like to thank Professor Valentina for the invitation, organizing this meeting. I have to say also add that my interest for mycology is one of the reasons is also Professor Valentina.
Thank you very
much. And I started to learn more about mycology. I worked in different fields of microbiology. Now, in the last part of my career, it seems that I will work more in the invasive fungal infection. Why is that? Because since 2003, we form a hematology committee for treatment patients with hematology malignant disease. And part of this committee is also microbiologist, and every week we have a meeting and we learn about immunocompromised patient treatment related to hematology, leukemia, lymphoma. And we know that we also, in the microbiology part, we have to learn more about fungal infection. About mycology, we can discuss how it's developed in our country, in different countries, probably the same situation. I will present cryptococcal meningitis after liver transplantation. Maybe it will not be typical case report as a colleague may follow those a bit with some mission. Why we choose cryptococcus? I will present a very complex case for us. You will see it was challenging, not for a microbiology laboratory. We were thinking, but we were lucky that we confirmed diagnostic. But it was very challenging for clinician because I will say it was our first confirmed case in our laboratory for the first time. Even we perform allogenic autologous transplantation. We have different discipline. We are a clinical hospital with 1,200 beds. We are regional hospitals, but we never before confirmed any cryptococcal infection. That was first case. First, we were happy. Unfortunately, comparing with the first case, it wasn't a good outcome. It was a lethal outcome. And that's, I choose this, it's a really education for everyone, for microbiologists and for clinicians. And we can discuss about that. Cryptococcus is also on the priority list as a pathogen, probably you know, and I will remind you, again, I missed some, that there are two main species which is connected to fungal infection. One is in Cryptococcus formans in worldwide distribution, in mostly the infection caused in immunocompromised person. Second is Cryptococcus gatti, is some, we say, endemic region, tropical, subtropical region, and mainly infection can cause in immunocompetent person. That's two differences. Very rare we have infection with Cryptococcus neoformans in immunocompromised, in immunocompetent person. That's mainly difference. Role of transmission. The main role of transmission is inhalation of spore, which are in environment. Professor Mihail talked about environmental distribution of spores, and spores coming to others, and we are exposed very early in our life to cryptococcal. spores, but if you have a good immunity, you will solve this infection. But in some person, one of the way possible way infection is the novel inhalation spore. Second, what is very important in immunocompromised person is that you have latent infection that you can later, especially in the state, even severe immunosuppression can be reactivation latent infection. There's two ways of possible infection in our patient. What is most dangerous in pathogenesis is that there is possibility then that cryptococcal spore can break blood-brain barrier and come to central nervous system. And one of the main topic tissue is central nervous system. It's act like Trojan horse because it survive in macrophage and it can enter barrier in macrophage. If we there's always risk different infection in solid organ transplantation comparing with other solid organ transplantation. Liver infection with cryptococcal infection is not often frequent, is 0.5 percentage. Therefore, we can maybe thus this case is rare generally. When if we look in the timeline when it's possible to have a clinical presentation, there's two period we say. One is very early, is very late. There is only some case report just in very first months. More often is after 3 to 6 months, or maybe in late after 12 to 40 months when we have reactivation. Very sporadic after 2 to 5 years. Why is it important to know? We have a very severe immunosuppression patient with liver transplantation. And this immunosuppression lasts for a long time, and there is always possibility to get some opportunistic infection or to have reactivation existing infection. The mortality rate is very high. Even if we have a treatment, it can reach maybe more than 50% of cases. Therefore, it's important to recognize, to confirm very early diagnostic, and to start with the treatment. Why is also tricky for clinician to recognize clinical presentation? Because there are some common symptoms, and they are also not always, I would say, so important for meningitis. Even in 70%, clinicians will not detect meningeal signs, and they will not indicate lumbar puncture, what is main diagnostic procedure. And that, therefore, we have a delay in the diagnostic, delay in the treatment. There are also possibility that we have a different, besides central nervous system infection, we can have pulmonary infection, we have cutaneous infection, or we have one temporary state fungal. Diagnostic is a main diagnostic procedure when we talk about meningitis is lumbar puncture, and what we'll find is increased on the cells, not so increased, but moderate increase of the cells, and mainly cells are mononuclear cells, which we can say lymphocytes. We have increased protein concentration of protein in the cerebrospinal fluid and decreased glucose in the cerebrospinal fluid. We can compare differential diagnostic with some other cases I will show there. What we should consider diagnostic, because we have a liver transplantation, patient with liver transplantation, immunocompromised, everything can be. With this finding of recall, cerebrospinal fluid, when we examine the clinician, he also should think about TB meningitis, listeriosis very often, or some neurotropic virus, or maybe tetanus aspergillosis. That's generally introduction. Now I will present a case that's 55-year-old female. She had end liver stage disease. It was primary biliary cirrhosis. And it performed living unrelated liver transplantation. It was done in Turkey, but control of the patient was in our hospital, and it was done 2nd January. I also surprised us after New Year, and the immunosuppression treatment was with tacrolimus and mycophenolate to the standard immunosuppressive regime for liver transplantation. To understand main action of tacrolimus is inactivation of T cells, action on T cells. Mycophenolate act on the lymphocyte, stopping proliferation, and B and T cells. It means giving this immunosuppression, we can deprive action of lymphocytes, especially T cells, which are very important for defense against fungal infection. Patient, after several months, was admitted on 14 October 2025. It was like reason for admission, schedule arranged admission due to progressive deterioration of general health. Patients have general weakness, severe malaise, and abnormal discomfort over the preceding days, and it was arranged to be admitted at the gastroenterology internal medicine department. It was presented with low-grade fever measured up to 37.50. Nothing special in the beginning. They admitted at the gastroenterology and they performed almost next 14 days. When you look in the report, many different laboratory findings, consultation, they started with some treatment, and it's going day by day. And just you can see that what is important, that patient have a low number of leukocytes, special low number of lymphocytes. You see the bilirubin was increased, total proteins, and we have, you can see, I will not read laboratory findings, just you can look at the laboratory findings, what is important. Then gastroenterologists invite several consultants. There were neurology consultations several times, infection disease consultation, because patient was not good. They examined patient, they said, okay, but it's not indicated for lumbar puncture, it's not indicated to do that, just continue with the treatment, regular treatment. Then clinical shift change happened on 22 after towards 8 days. There was urgent neurological consultation requested due to acute clinical deterioration. Now we have a change in the neurological, some psychiatric changes in behavior, in mental status, something what is indicated that something happened maybe in the central nervous system. They indicated MRI, and they found ventriculitis. I spoke with the radiologists. They say there's nothing special in the meningitis, but they want to say extension of the common system and the ventriculitis, comparing with the previous findings. Then they also asked for flow cytometry analysis. I already mentioned that there was a low number of lymphocytes. You can see very low number of T helper lymphocyte and T cytotoxic lymphocytes. We can expect different viruses and special fungal infection in these cases. That was expected. And just to see, patient came with some problem with increased creatinine, and then later at the end we have a kidney failure as additional complication. And because of several ill patients, they asked to transfer patient in intensive care unit. It was 14, almost like 16 days after overseas patient at the gastroenterology department. And the 30 October, after 2 days admitted to ICU, infectious disease and neurologist agree to make a lumbar puncture. That's first diagnostic test after almost 16 days. 16 days. And we found it was done biochemical and cytology analysis, and you can see, as I said, one of the signs possible connected with the meningitis that we have an increased concentration of protein, low level of glucose, and we increased number of cells, and many cells are mononuclear, but it was lymphocyte. That's one of suspicion that we can have meningitis caused by fungal, but sometimes we can also listeria or some other virus can have the similar findings. We got microbiological examination of cerebrospinal fluid. It was almost at the end of a regular working day. In the afternoon, I was at that time at work, accidentally or intentionally, and they called me. They will send cerebrospinal fluid. Okay, I order immediately 2 main gram stain. We regularly do gram stain. We don't have tolerating group what is necessary in order because we didn't expect. At the same time, another lucky we have biofire, and I already immediately arranged to do biofires and meningitis encephalitis panel. At the same time, PCR biofire finished. At the same time, I was examining slides. I got confirmation on the that detected Cryptococcus pneumoniae gatti. That's like that don't discriminate. And I look at the lab stains. What was surprised that I saw many blastospore in the slides. You know, usually if you have some meningitis, you see several, but there are almost many numbers, big numbers. This heavy load of cryptococcal infection already exists in that patient. That can cause complication on the leak for common system and other complication in the brain. We also catch a system almost after 24 hours. Very fast we could see drought. After 48 hours we had complete SDA agar, and we made the multi-top identification. It was confirmed Cryptococcus pneumoniae. That's microscopic examination of exam saying that you can see there is difference between even if you are experienced, but for us it was first time that we see on slides that, but you can, if you look carefully, you can see difference between candida and between blastospore of cryptococcus. Usually you can see even like halo against, which is not also stained by gram stain, it is part of the capsule. But if we didn't have this biofire panel system, it would be difficult to say the same hours we found that. We will say we find some, it is yeast, but we have to care what is patient, who is patient, what is comorbidity, and I don't know, we had to wait that time for tomorrow. I call, it is our general practice that I call immediately infectious disease and doctor in ICU to inform that we detected in the Microsoft slide and the PCR detected Cryptococcus pneumoniae or Cryptococcus, and immediately we also inform clinical pharmacologist, and we agree for the treatment. They immediately start with the treatment. For diagnostic gold standard, you know, is also culture. Is this morning Professor other colleagues from the Greece, he mentioned rapid antigen test. We don't have rapid antigen test. Even we put several times on the tender, but nobody is exchanging for few tests to sell. Therefore, we don't have also India Inc. And but we regularly do culture. For the management, what is important? Now we need aggressive antifungal induction treatment. If you're a clinician and if you're also on the other side consultant microbiologist, you have to take into consideration toxicity of the antifungal drugs. You already have a patient with a failure in the liver function, with immunosuppression, and you have to choose some drugs which have toxicity, amphotericin, which is nephrotoxicity, your fluconazole, which is increased activity of the immunosuppressive. It means that you have a work with the immunosuppressive reduction, but if you stop, maybe decrease higher immunosuppressive reaction, you can have iris, immunoconstitutional inflammatory syndrome. You have to also think about that. Therefore, for clinician and the people who decide that the treatment is really difficult, tricky, how you treat this patient, especially if you have for the first time this patient. If you don't have experience in the past, it is difficult. That's regular treatment according to IC guidelines. You have an induction phase, you have a consolidation phase, then maintenance phase. It's very, even for me, it was very complicated for treatment. We had in our pharmacy, we have a liposomal amphotericin base. We started, and when we agreed that we should also add fluticasone, but we don't have fluticasone. Even in all this region, I think in the Serbia, I don't know, nobody provides fluticasone. Then you have alternative. You have to add liposomal amphotericin plus high dose of fluconazole. Fluconazole, I said, had activity on the immunosuppressive drugs. And they started, it was almost 1st November with the treatment. Unfortunately, after on 9 November, patient finished with fatal outcomes. There was, they made after 7 days controllable action. It was sterile. And we also, just for us, it is not regular, perform again multiple PCR. We expect, like for the also SARS, that we have a nucleic acid. It was positive, but there was no drought. It means they cleared cryptococcus, but they had a lot of complication. It was really complex patient with the kidney failure and unfortunately with the fatal outcome. Take-home message for us, for clinician and for laboratory. It is very important to, in a high index of suspicion, to know when we have people with the solid organ transplantation, especially if you don't have many patients. You have to learn more. If you just have several patients, it's okay for some Western country if you have a special hospital with many cases, they are experienced. Now we learn, still learn. Laboratory are, as I said, massive amount of years from basic gram stains, critical panic value, require immediate ISO restoration. Because it is one of worst prognostic factor. For syndromic testing, even if we don't have some test, I think it is important to have, as we mentioned this morning, this new technical molecular diagnostic, now one of the tests, depending what you have, and advocacy for the source. It is essential to have first-line antimicrobials. Fluticasone must be permanently stocked in regional center, especially in our country if we want to perform solid organ transplantation. That's all complexity that we learn a lot, and we have to change our laboratory work also. Thank you.
Thank you very much. Great presentation. And this was my first lab in medical mycology. I made my PhD on this yeast, Cryptococcus neoformans, and also master. Uh, do you have, now we can start with discussion, or Bojana, maybe you have presentation here, because we have a different concept. After presentation, we will move in another room to show results of our project. Did you put a presentation? Okay. Sorry?
This is on the
Do
computer.
you have the presentation on your USB? No? It is better to put on here because I don't time to.
Easier to manage.
I'm not sure. Maybe some of the details.
I think it should be.
Sad ćemo da zovemo ove devojke koje su ili internetu.
Što imate vi na mailu, jel? Na mailu, jel?
Da položim, evo pa ćemo da... Evo.
In meantime, I will introduce Bojana, Dr. Bojana Šalović. She is my student and she helped us very much to finish and to publish some results from our project Fungal Case Finder. Actually, she is gynecologist and affiliated with our hospital here in Serbia, but also with the gynecology hospital in United Kingdom. Okay, is it?
Thank you,
Okay.
Professor. Let me just...
You can take a seat if it is easier for you, because I think, oh, yes, great. She will show you the practical.
I will show you how to log in Gmail. I'm just kidding.
Okay, maybe we can discuss about these two wonderful cases presented by Professor Tadej Matos and Professor Mija Stihic. May I ask you the question? Do you have sorry, a PCR for molds in your laboratory for non-dermatophyte molds?
Yes, we have PCR for aspergillus
Okay.
and temporalis.
For which sample? Do you have only blood sample or?
So usually for so tissue, or also for blood samples. Primaries that are.
And what is your experience? Do you have no contamination?
And also for temporalis, especially in hematologic patients, because there are no antigen tests for these molds, and yeah, we have good results.
And how often your physicians ask you for this kind of diagnosis, and which type of tissue you usually receive in your lab?
So so we do all tests which are coming to our lab. We finished in the same day. So
Okay.
only if only send one, then we
But
perform others.
I suppose that this is biopsy sample, biopsy.
Yes.
Okay, this is lung biopsy or some
No, lung biopsy, it's very unusual.
very unusual,
Yeah.
okay?
So in hematological patient, they use they send us minimal,
Okay.
mini
Yes.
samples. Otherwise, in non-nephropathic patients, they usually send us bronchoscopic
Sample by
samples.
taken by biopsy.
And we use also PCR in cases when they, when in histology samples, they see hyphae
Okay.
and microbiology is negative, or perhaps they didn't send us.
Okay.
Yeah.
Did you publish this case?
So in this case, we perform first specific PCR. So for Aspergillus or for Candida, depends on the histology results. If there is negative, then we use also ITs as region for sequence.
Did you publish this case or you're preparing to publish?
Yes, yes, yes.
You're preparing.
Yes,
It's published already. Oh, congratulations. And also the same question for my colleague.
We
Yes.
have also Aspergillus PCR from the last year, but we didn't do a lot, many samples, but we started to do with Aspergillus sample. If it's a slight sample, then we also confirm with Aspergillus PCR. Mainly the samples are viral or respiratory samples, but what is surprising for me, because we work in the same institution for laboratory diagnostic, and I talked with the pathologists, that would be maybe one of the topics, histopathology. They, as you said, they detect even more often than we confirm in our laboratory fungal infection. Many successful biopsies. Therefore, maybe we need more collaboration. Common sciences is already got now all recover includes the DNA for analysis. Or we have like panel file for just genomic testing, and we want to expand with the locals, and also I sometimes I activate as well also for them like
Yes.
but nobody do it, but we want to improve that.
Great. Great. Thank you very much. Any question or comments from audience? Or we can move to the last presentation. Bojana, the floor is yours.
Thank you. Good afternoon and sorry for the delay. My name is Bojana Šalović and I'm going to talk about the personalized questionnaires for vaginal infections and present you a fungal case finder. So despite being very common in gynecological practice and clinics, vaginal infection, I think that clinicians still face some challenges with the diagnostics of these infections. It is mostly due to the overlapping symptoms because patients often come with some kind of irritation, itching, burning sensation, different kind of vaginal discharge, and also not very good smell of the vagina. And it all can be either fungal bacteria or it can be also a mixed infection. So speaking of mixed infection, there is a high prevalence of mixed infection, and it is not that uncommon that bacterial infection, bacterial vaginosis can coexist with some other pathogens. Also, there is a high frequency of the self-diagnosis, self-treatment of the woman, going to the drugstore and using over-the-counter medication. And it all leads to the antifungal overuse and, of course, to the change of vaginal microbiome. So what we need is the individualized diagnostic approach to every woman itself. So what is the problem with traditional diagnostic approach? So every woman that comes with some clinical symptoms, clinicians do the microbiological testing or swabs, and they then give a therapy, or they don't do. So they just rely on the symptoms and what they see in the vaginal discharge, and they just give empirical therapy. And that's the problem, because symptoms are subjective and also non-specific, as we said, and also there is significant inter-patient but also intra-patient heterogeneity. What that means? For example, inter-patient means if we have two women and they have the same condition, they will present with a total different clinical picture, but also in one patient, if we have recurrent infection, that recurrent infection can also present differently. We also have variation in the individual risk profiles. For example, diabetes. We need to gather more information and to ask specific questions to the patient if they had diabetes, if they use prolonged antibiotic therapy. What is their lifestyle? What is behavioral factors? For example, if they have a frequent sexual activity, is it do they use contraceptives, because hormonal fluctuation can affect also clinical picture. So one size fits all approach no longer exists in vaginal infections. So along with Professor Arsenievich, we performed a systematic review of the personalized self-assessment questionnaires. So we wanted to see how many vulvovaginal symptom questionnaires are there for assessing symptom signs and risk factors in patients. These are inclusion-exclusion criteria. So what we got, let me just first show you. So this was our table. We included 14 studies, and guess what? Only one of them, which is the first one, actually was fully developed questionnaire, was validated on different populations, and also it was available in multiple languages. Only 7 of these evaluated symptoms at all, and none of these focused on pregnant women, which is considered as a huge gap in literature. The number of questions ranged from 10 to 30. So what are the questions that we need to ask a woman in order to draw some conclusions? Also, this design of these vulvovaginal questionnaires were all different, so it was difficult to draw any coherent conclusions. Even if you type in now in a Google, for example, for the questionnaires for the candida, for the vaginal infections, you will have a lot of quiz-like questionnaires there that are not developed, they're not validated, and also they're not developed by the experts or clinician or specialists. So women, I think they often they are eye-catching, which means that they're just trying to gather as many viewers as possible for their websites. And women that do that actually relies on the results and then go to the drugstore and self-medication again. So what we did, so our team actually developed Fungal Case Finder. It is a digital triage tool, and it was designed as a clinical decision support system. So we actually relied on 4 P's in medicine: personalization, participation, prediction, and prevention. And this tool actually uses individualization for every patient, and also give opportunity for the patient to take part in their own condition, their own treatment. And our guiding principle was that the future of diagnosis begins with asking the right questions. So this tool consists of 4 major parts. It is demographics, risk factors. We're trying to gather as many information as possible. And then the woman will actually fill in signs and symptoms. And if there is a necessity, we have microbiology testing as well. Let me just show you how does it look like. So the first question that woman is filling in is that she is actually, you see the pictures here. So she chooses the picture that corresponds the best to her vaginal discharge. And then she notes how many days or what is the duration of the symptoms. Then she giving the answers for these three groups of the questions: symptoms, signs, and vaginal discharge. If any of these answers is yes, then she also mark it as low intensity or high intensity of symptoms and signs. And what is the result? Then we go back, and for every question that she marks, she gets points. So if the result is 0 to 9, she will have low probability for vaginal infection. If it is more or it is 10, she likely infected. So what is the next step? There is a request for consultation if there is a need for one, and then she will have opportunity to be presented to talk with experts who will actually guide her further if, for example, laboratory findings are needed and testing. So clinical benefits of this tool are definitely early recognition of the symptoms. And what I like the most is that I think that women are somewhat embarrassed to talk about their vaginal health, vaginal discharge, their sexual activity, menstrual history. So she can actually give more reliable answers to this because she will do it on her own private phone at her comfortable place, which is her home. And I think we will have better patient stratification in this case. And this all will lead definitely to unnecessary antifungals use. What are potential applications? So definitely clinics in gynecology, outpatient fertility, pregnancy, and also as a self-assessment application app, like an app, which is actually what we're trying to do. We acknowledge some limitation of this tool. So this questionnaire, it's not definitive diagnosis. And also this is developed in English and Serbian, and that's why we face still the language barrier here. We did not skip overlap infections, and of course, we still need microbiological confirmation in order to diagnose this woman. Future directions. So it is wearable. You can always have your vaginal health in your pocket, how I say, at your mobile phone, and also you can integrate this tool with electronic health records, which means that if you have your history for how many days did you have infection, how often does it develop, we can create some predictive recurrence models on that. So from all of these, I think I can draw one sentence conclusion, and that is that personalized questionnaires represent a bridge between symptoms and signs on one side and the accurate diagnosis on the other side. So I think that if we ask only one right question can be a piece of puzzle that is needed to complete our diagnosis process. Thank you.
Thank you, Varuna. Great presentation. Thank you very much. You can take a seat. This topic we will have tomorrow more deeply inside, and Varuna will be also here. But if you have any question, because this is part of our very complex project, and yes, please.
In this question, also allow the laboratory
Uh,
because we have a big problem with know how to report vaginal swabs. If you don't know what is their situation, is a pregnancy, if there is some discharge, what we will report everything what we found is not okay, or we will be something. There's a problem generally in the vaginal.
Okay, the answer is crucial. The question is crucial, and we have answered. In the next step, we will show you the software, which is include the laboratory part and also follow up, how to follow up the patient. And this is one electronic record, as Diana just told. But maybe you have some other answer.
No, I think that the software that we're trying to implement that will record all of this. So you will have steps, for example, for every laboratory findings, like what to do, what is the next step,
And also we have innovative tool for taking samples. And this we will show you today during this practical workshop. It was our idea to present really that this is the software is protected, but these innovative sampling tools for mucosa, for example, or for nail or for chronic sinusitis are still under development. And we will show this, and also we can discuss about this, and maybe your suggestion will be very helpful for our next step, because we hope that in the next step we can use we can make another project with benefits for the patient and physician. And this is ongoing. Okay, thank you. Do you have any question or comment, please? Okay, if not, we can discuss in the other room, and we will show you our mobile app software or medical report, and also our new innovative tools, and discuss a little about this. Ovako, možeš da je staviš na desktop u sesiju 2, znaš, jer moramo da šaljemo ekran.
Ok, nema problema.